Hi, my case study is called Mr. G. I'm at Watauga Medical Center, and this is obviously my clinical rotation. To start off, okay, there we go. To start off, I'll give a review and clinical update of the respiratory system, aspiration pneumonia, and refeeding syndrome. My patient was never diagnosed with refeeding syndrome, but it was something that we were monitoring for because he did come in severely malnourished, and then I'll go into his actual course of treatment. So review and clinical update, some terminology, just hypoxemia, a condition where there's inadequate supply of oxygen in the blood. Surfactant is a substance secreted by the alveolar cells of the lungs that serves to maintain the stability of pulmonary tissue by reducing the surface tension of fluids that coat the lung. A tracheostomy is a surgically created hole in the trachea that provides an alternative way of breathing. Mechanical ventilation is artificial ventilation using a ventilator or respirator, performed with a piece of equipment designed to intermittently or continuously assist or control pulmonary ventilation. Pneumonia is an inflammation of the lungs, usually caused by bacteria, viruses, or fungi, and I'll get into aspiration pneumonia in a couple of slides. So normal function of the respiratory system, there are two tracts, obviously the nose, nasal cavity, frontal and maxillary sinuses, pharynx, larynx, and trachea all form your upper respiratory tract, and you can see that's kind of everything from the trachea up, and then the lower is everything going down, and that's the lungs, bronchi, bronchioles, and alveoli. And air flows in through your mouth or nose, goes through the larynx and into the bronchi, which kind of branch off into bronchioles within the lungs until they get to the alveoli, and that is where ventilation and that's where the gas exchange occurs. Ventilation is just the in-out of breathing, and that is your skeleton, the muscles surrounding that, like your intercostal muscles and your diaphragm, are the muscles actually responsible for the ventilation of the lungs, which allows for that gas exchange to occur. So aspiration pneumonia is when inhaled materials cause a response in the lungs. So it's when they cause an inflammatory response in the lungs, and these inhaled materials can really be anything from saliva to nasal secretions, bacteria, liquid, gastric contents, pretty much anything inhaled. So risk factors are a decreased level of consciousness, neuromuscular disease, and structural abnormalities of the upper GI tract, ET tubes or ventilation, vomiting, delayed gastric emptying, advanced age, prolonged supine position, gastric enteral tube feedings, bolus feedings, or a large diameter of a tube feed, or a malposition tube feed. And everything that is highlighted in red is something that my patient had at some point during his treatment, either before he came in or kind of when he developed, or something he developed while he was in the hospital. Traditional practice recommendations, really on the nutrition side, we pretty much use the evidence-based recommendations, which are that the head should be 30 to 45 degrees above bed elevation. And then you want to monitor your gastric residuals about 200 to 500. You should definitely watch for those, but they shouldn't be a contraindication for enteral feeding unless you have other signs of intolerance present, like vomiting or diarrhea. You definitely want to monitor those, but they're not a cause to stop. Gastric residuals over 500, then you want to look into using a promotility agent or adjusting the rate of the tube feeding. And a common promotility agent is metoclopramide, also known as Reglan, and that is something that my patient was on at his long-term care facility. So refeeding syndrome refers to a serious metabolic disturbance that can occur in starved and or malnourished patients after the recommencement of feeding, either enterally or parenterally. Classically, you will see decreased serum levels of phosphate, potassium, and magnesium, although other electrolyte abnormalities can be present as well. Risk factors for that include little or no intake in the recent past, significant recent weight loss, low BMI, electrolyte disturbance prior to feeding, specifically the ones I mentioned earlier, potassium, magnesium, and phosphorus, and then history of alcohol and or drug abuse. And with refeeding, what causes that shift in the serum levels is when insulin is released in the blood as a response to glucose. The sodium potassium ATP transporter cells present on the cells is stimulated, and that causes a dramatic shift of potassium and phosphorus and water through osmosis from the extracellular compartment to the intracellular compartment. And that decreases and that moves all those ions from the blood into the cell, causing those low serum levels. And this condition, if it's not treated, can be fatal. So Mr. G, he is a long-term care resident of a skilled nursing facility, Glenbridge, for those who are more familiar with the area. He has a history of severe Parkinson's with deconditioning, chronic aspiration pneumonia, and chronic peg tube. This peg tube was placed in April of this year, where he also had a trach placed, but that trach was later removed. He eats PO during the daytime, and he has 2 feedings nightly of Osmolite 1 cal, bolus 3 times throughout the night with 150 milliliter water flushes before and after each feeding. And you can see here on the right, I have a detailed list of his weights over the past 2 years of when he was in the hospital. And you can see at 4/19, he was 144.7 pounds. And at today's admission of 10/19, he had dropped about 20 pounds. And that for him was about a 14.1 or 2% weight loss. And at the time of admission, we didn't know why he had lost that, because we were like, why is this guy losing weight? He's at a long-term care facility. He has a peg tube. Like, why is he losing weight? And I'll kind of get into the reason why he was losing weight as we discovered it throughout his course of treatment. Oops. So current personal information, he's a 69-year-old white male. He's 6 feet tall, 124 pounds at this admission. He was admitted on 10/9 from long-term care facility after being found hypoxic and lethargic. This patient is a known aspirator, and so he had similar episodes like this before. Prior to the admission, on 10/7, he was admitted for a nonspecific fever and was subsequently discharged that day. I've been reading a little bit more about aspiration pneumonia, and that can present with a fever. So while the two were never formally linked, maybe that fever was related to his subsequent aspiration pneumonia. He's a full code when he came in, former smoker, current tobacco chewer, and denies drug and alcohol abuse. His mother died at 75, and his father died at 52. So he has a long list of medical conditions, and I'll only really go over the ones in red because those are the most pertinent to this case. So he has recurrent aspiration syndrome secondary to Parkinson's disease, severe protein-calorie malnutrition. When this guy came in, he really did look like a skeleton. He was very thin, very malnourished, and very obviously so. Chronic peg tube, again, it was placed in April. And sacrodecubitus ulcers, when he came in, he had 3 stage 2 pressure ulcers around his sacral region. He also has a long list of home medications that he's taking at his long-term care facility. Since this is a nutrition class and not a pharmacology class, I will focus on really just the medications that were relevant to us. And so he's taking Remeron, also known as mirtazapine, and this is an antidepressant also used as an appetite stimulant. Potassium chloride, used to treat his low potassium. Reglan, also known as metoclopramide, is a GI prokinetic, which I talked about earlier. An even longer list is his medications during his admission. So again, I'll just focus on the ones that are pertinent to us. He received several electrolyte replacing drugs, so calcium gluconate, magnesium sulfate, potassium chloride, ferrous sulfate, and potassium phosphate and sodium phosphate. Potassium phosphate and sodium phosphate are also known laxatives, but in this case, they're used as electrolyte repletion. And then highlighted in blue are the drugs that he was sedated with when he was on mechanical ventilation. Here are his labs. pretty much you can see that all of his electrolyte labs are very low. His renal labs were low. And then you can see particularly with potassium that around 10, 11, they really dropped to be 2.7. Sorry. And you can just see, even though we were replacing all these electrolytes, they remained low, which, and on top of that, we were feeding him. So this could have been a possible indicator of refeeding syndrome since they remained low. So multidisciplinary considerations. Definitely MD and pulmonology were responsible for direction of care and dealing with kind of all the things that came his way. This patient came in obvious respiratory distress, needed ventilation, needed oxygen. So pulmonology was definitely very important. Nursing on our side, the nutrition side, definitely monitored the tolerance of his tube feedings, measured gradual gastric residual volumes and other symptoms, in addition to providing suction, providing care, pretty much doing it all. And then the SLP, he would be a primary candidate for a swallowing eval. And then pharmacy, since he was on TPN, while the nutrition department at our hospital does the rate, pharmacy is the one who distributes that. And then they also worked with the medical team for dosing and antibiotics. Course of treatment, as I said earlier, he came into the emergency department with acute hypoxic respiratory failure related to aspiration pneumonia. He was hypoxic with obvious respiratory distress, decreased mental status, abdominal pain, and he had a suspected short bowel obstruction. And he was thin and cachectic appearance. As I said earlier, he's very malnourished, septic with 3 stage 2 pressure ulcers. He was intubated in the emergency department because the physician there did not think he could adequately protect the patient's airway. He was admitted to the ICU. At this time, an OG tube was placed to suction and 2 liters of dark fluid were drained, as well as dark fluid was also in the PEG tube, and this also contributed to the impression that the patient might have had a bowel obstruction. So on 10/10, the patient remains sedated. He was receiving TPN per protocol due to his partial short bowel obstruction. The goal rate of the protocol is 83 milliliters per hour, 15% dextrose, 5% amino acids continuous with 250 milliliters of 20% lipids piggybacked per day. And this provides 1,914 calories and 99.6 grams of protein. And the formula we use is Clinomix E. His estimated needs were 1,550 based on Irene Jones ventilator dependent. He needed 56 to 67 grams of protein based on 1 to 1.2 grams per kilogram. And this was because he had those pressure ulcers. Diagnosis was malnutrition related to inadequate energy intake as evidenced by a 14.2% weight loss in 6 months, observed fat loss in the orbital area, and observed muscle wasting in the temporal and clavicle bone region. Our intervention was to recommend that the TPN goal rate be lowered to 65 milliliters per hour, and this would provide him with 1,608 calories and 78 grams of protein, which meet his needs. So on 10/11, the patient self-extubated. He had a bowel movement. His acute kidney injury resolved. Septic shock also resolved. And then they planned to slowly advance his PEG tube feedings the next day on 10/12. So 10/12, he was on a mechanical soft diet and also on TPN, which had been decreased to 35 milliliters continuous. Overnight tube feedings were scheduled to resume later that day, and we wanted to do a trickle feeding at first, mostly just to stimulate any hunger response. And so we wanted tube feedings to begin at 8 p.m. to 6 a.m. of isosaurus 1.5 cal at 10 milliliters continuous for 10 hours. And tube feeding and TPN combined will provide the patient with 1,246 calories and 48.8 grams of protein. We were also going to provide him with a boost pudding in addition to his meals, providing an extra 230 calories and some grams of protein per serving, in addition to whatever he was getting with the mechanical soft diet. And on this day, we also learned the reason for his probable weight loss, and this was that the patient had been refusing his bolus feedings during the night. The nursing staff at Glenbridge reported that he had been eating during the day, but it hadn't been very much, and then he had been refusing tube feedings at night because they didn't make him feel well. And so that's how he lost all that weight, is because he was just refusing those feedings and then just otherwise not eating as well as he could have been. So on 10/12 continued, we wanted the tube feeding to begin slowly, and this is all for future care. And so in addition to being slow, we wanted it to be continuous because he had reported not tolerating bolus feeding well. And a goal was our nightly tube feeding to provide 750 calories at a goal rate of 50 milliliters of isosource 1.5 for 10 hours. And this would be adjusted based on his PO intake and weight. So on 10/13, he aspirated again and needed to be intubated. He was mildly sedated on the drugs I talked about earlier, and he continues to receive TPN, but the plans were to reduce that TPN and advance his tube feeding, and they were going to decrease the TPN per protocol and increase the tube feeding to 25 milliliters an hour, then increase by another 10 every 8 hours to achieve a goal rate of 45 milliliters per hour. Patient was also to receive 30 milliliters of Promod daily, and this would provide the patient with an extra 300 calories and 30 grams of protein. In addition, the MD ordered 150 milliliter water flushes every 6 hours, and this is going to provide the patient with 1,620 calories, 73 grams of protein, and 825 milliliters of free water, excluding water flushes. So on 10/14, nothing really eventful happened. So I skipped ahead to 10/15, and just the patient remains intubated with minimal sedation. He is at his goal rate of 45 milliliters per hour, and the MD notes that the patient desires for a trach placement. So on 10/16, he's still on the ventilation. This patient had kind of flip-flopped back and forth with the trach placement. So he had some notes where he had requested the trach placement, and then others where he was like, I don't want this, all according to the physician and nursing notes. But ultimately, he did report to pulmonology that he did not want a tracheostomy. And pulmonology believed that a trach would help clear secretions, but would not provide benefit in managing his chronic aspiration or subsequent pneumonias. And this procedure would be a lifelong procedure, which would ultimately not improve his prognosis. And then in the afternoon, the patient pulled his ET tube partially out. It was removed in addition to with the OG tube. His respiratory status at the time was stable, so he was not reintubated. And also at that time, he had a long discussion with palliative care, the hospitalist medical team, and I believe the chaplain was present as well. And at that time, they did not receive a clear direction of care. In the notes, in the MD's notes, it stated that the patient seemed like he was really struggling with the fact that he did not want a trach placement, but he also did not want to die. So on 10/17, he remained off the ventilator. His respiratory status worsened, but was still relatively stable. Had some vomiting. Again, the pulmonologist noted that reintubation would also not help the overall situation, as it would not correct his underlying problem of chronic aspiration. They were going to do a capacity evaluation because his ability to understand was called into question. An ethics committee was involved, and they finally got the family involved. And at this time, the family and the patient with the medical team had a long discussion about patient care. And the patient finally made a decision that he wanted to do comfort care only. His last recorded tube feeding was at 1,800 at the goal rate on 10/17. So on 10/18, again, he became comfort care only, continuing just on pain medications and scopolamine to control his secretions. And the medical team anticipated his death. he was transferred out of the ICU onto the med-surg floor. And on 10/19, he died at 4:50 a.m. So conclusion, this case really highlighted the fragility of the respiratory system for me, as well as my other case study. Both my case studies had respiratory conditions and ultimately need ventilation, and ultimately had both of them died. And it just kind of these two case studies really highlighted that fragility, because like 1 minute you're fine, and then the next minute you can't control your secretions and your breathing, you can't. And then also this highlighted the importance of the nutritional status pre-admission. Of course, what we learn is we learn that it's so important. And then this was kind of the first instance where it was like, what if this guy had come in with better nutrition? Would he have had a better outcome? Which we will never know. But this was definitely kind of the first case where it really brought it home, where it's like, maybe this guy would have been it would have been different, maybe. And then also going back to his nutritional status, is he came from a skilled nursing facility. So why wasn't his weight loss addressed at that facility? I do know that they have a dietitian, although I believe that dietitian is part-time. So at some point, some level of care was dropped in terms of addressing his weight loss and his discomfort with enteral feedings, because there are things that we could have done to, or someone could have done to maybe make that better, like changing the formula or changing to continuous. There were other things to try than just letting him refuse it all the time, instead of just finding a way to fix what made him uncomfortable. And then overall, this is a really challenging end of life case, especially towards the end with his first discussion with palliative care, is between him not wanting to die, not wanting to receive a trach, which again wouldn't help him anyways. It really felt like the patient just had to choose his own death. Did he want to die later, or did he want to die sooner? Like, which way do you want to go? So that was hard to be a part of in terms of just the medical care team, but like just thinking about how hard it must have been for him and his family, it must have been very challenging, and definitely brings up a lot of philosophical questions. But anyways, I hope you guys learned a lot from my presentation. Thanks.